Well, good afternoon, everybody. I think we'll go ahead and get started. Thank you for joining us on today's session of It's Worth a Shot, April 13th, 2022. I will have you know that this is also the 13th edition in our series. Today, we're going to cover regulatory updates and vaccine record access. Next slide, please. As always, feel free to add in the chat any webinar topics and clinician ideas or needs, or any ideas at all into our chat box. We definitely invite those as we look to continue our series through the end of the year. Next slide, please. And today also we'll insert a little public service announcement as we are only 16 days away from the National DEA Take Back program on Saturday, April 30th. This initiative, they typically do it twice a year, and it's an opportunity to dispose of unwanted medications. The last collection, they collected 372 tons of medications across the country. Next slide, please. So with that, I'll introduce Jill Holt. She's going to present on the first portion of our series today, regulatory updates. Jill, you have the floor.
Thank you, Jessie. Welcome, everyone, as Jessie said. I'm Jill with Mountain Pacific, and I'm going to turn off my video, save a little bandwidth, and then just focus on my portion of the presentation today. We decided that we would speak a little bit about the recent updates. Last week, we received some clarifications on attachment A, and then also we received some information regarding the stopping of the waivers that had been put into place during the public health emergency. So let's start with just what I've done is really just highlighted the changes that, or the clarifications that CMS provided us regarding the vaccine mandate. And these can be found in attachment A. Attachment A is specific to long-term care facilities, and so it's really meant to be a supplement and used in conjunction with the QSO memos 22.7, 22.9, and then QSO 22-11. So let's move to the next slide, please. So these are just some highlights. I urge you to look at that attachment if you have any questions. CMS did a nice job of illuminating the changes or the clarifications in red when you pull up that attachment. But for the purposes of our presentation today, they're in blue on our PowerPoint slides. So let me just kind of roll through these. And if you have any questions, we'll do our best to try to address those. And if we don't know the answers, we'll find them out and then send that back out to you in the FAQs that we produce each week. So there was some clarification regarding the temporarily delayed vaccination and what that means to defer vaccines. So basically this language just refers that, or articulates that vaccinations can be temporarily deferred if they're per the recommendations of the CDC. And we know those recommendations to be a known COVID infection. You can defer a vaccine until that recovery if there were symptoms, and that also the person with COVID-19 has met the criteria to discontinue isolation. So those are kind of some boundaries or some resources you can refer to if you're wondering if somebody meets the eligibility for vaccination and how to count them in your numbers. Next slide, please. So we know that the surveyors had begun surveying the QSO 2207 and 2209. And the reason you might remember there's two different memos is because initially there were some states, I think there were maybe 10 states or so, that sued the federal government for the vaccine mandate language. And so there were some states that started the vaccination mandate ahead of some other states. And so that's why there are two different memos. And I think I think everybody except Hawaii fell into the 2207 category. So, and you can reference those. We'll send that out also when we send out our links next week. But I think it's also important to note that if this is part of that language clarification in the recent attachment. So if facility staff who've been suspended or on extended leave, i.e. like an FMLA, perhaps there's a workers' compensation leave, those folks would not count as unvaccinated when determining the compliance with this requirement. So this guidance helps the surveyors to determine the severity of a non-compliance deficiency. So that I think that kind of makes sense, and it seems obvious, but I think it was helpful that they clarified that for us in this attachment. All right, next slide, please. So this is this caused a lot of questions, I know, in the state of Wyoming where I work. And it took kind of a minute to sort through what the intent was of this 483.80 FTAG regarding the vaccination. And initially, the questions that we had were whether these modifications were requirements or whether they were suggestions. And so CMS has come out now with a clarification that these samples of modifications, for example, for unvaccinated staff, can include but are not necessarily limited to, and then you can read for yourself, but a lot of these are reassigning staff to non-patient care areas, utilizing a different source control. I know, for example, in my state, there was a lot of discussion about the use of N95s for unvaccinated staff. And so CMS did clarify that this requirement does not give explicit actions that you must take in your facility. They're not all inclusive, and they don't represent all the actions that could be implemented. However, facilities can choose other precautions that align with the intent of the regulation, which again is meant to mitigate the transmission and spread of COVID-19 for all staff who are not fully vaccinated. So hopefully you are aware of that. You may well decide to utilize an N95 for staff that are unvaccinated, but it is not necessarily a requirement. You do want to make sure also that whatever it is you decide to do in your facility, that your policy and procedure manual support that and articulate those practices. And then make sure your staff understand that and that they know where to find that manual or that guidance, so that if they're pressed during a survey or during an inquiry, if they get nervous, they know where to look, and they would be able to send a surveyor to that particular resource site. All right, next slide, please. This is, again, some information regarding the survey process for FTAG 888. The surveyors will be looking for vaccination policies and procedures. They will look for the number of staff and resident COVID-19 cases over the last 4 weeks. They'll want a list of all the staff and their vaccination status. And then they will want and ask you for information on how you as a facility ensure that contracted staff are compliant with the vaccination requirement. So this particular clarification speaks mostly to contracted staff. So the list of vaccinated staff maintained by the facility or the staff vaccine matrix are used for sampling staff. That's how CMS determines what their sample is when they come in for a survey. So they'll review the compliance, compliance for the above requirements. And this will happen during initial certification surveys, recertification surveys, and complaint surveys. Surveyors can modify the staff vaccine compliance reviews if they were just in your facility and reviewed this within the previous 6 weeks. So if you had maybe you had a complaint survey and they asked these questions and reviewed all of this, and then within 6 weeks you had your annual recertification survey, they may not then have to review the same information if they had just been there within the last 6 weeks. And also, life safety code surveys do not have this investigation requirement. All right, next slide, please. This articulates the scope and severity for citing noncompliance. And this again, most directly speaks to contracted staff. So failure of contracted staff to provide evidence of vaccination status reflects noncompliance and should be cited at an F88 under the requirement to have policies and procedures for ensuring that all staff are fully vaccinated, except for those who have been granted exemptions or a temporary delay. Now, if you have staff that you contract with, suppose you contract with a therapy company, you yourselves may not have those particular staff members' vaccination records, but if you're under a survey, you will want to make sure that your contract details that you have access to that information by perhaps contacting the manager or the operator of that particular contract. So you will have to be able to gain access to that information should you be asked by a surveyor. All right, next slide, please. There is some good faith effort language in the attachment. So facilities should be able to provide evidence that you've taken aggressive steps to have all staff vaccinated, such as advertising for staff, hosting vaccination clinics, etc. So for example, if the facility staff vaccination rate is 90% or more, and there is no resident outbreak in the previous 4 weeks, and all policies and procedures were developed and implemented per the table we'll share on the next slide, then you would be cited at a D, scope and severity. However, if the facility provides evidence that it has made a good faith effort by taking aggressive steps to get all staff vaccinated, surveyors may lower the citation to an A. So if we could go to the next slide, Mary, please. I think that'll. This is a really nice scope and severity grid, and it's specific to FTAG 888. So this language here in the far left column will help you to anticipate and navigate if you're in a survey situation, what you can anticipate to be a scope and severity and how the surveyors will be guided for that decision making. All right, next slide, please. So I want to shift now to the blanket waivers that went into effect during the initial phases of the emergency pandemic period of time declaration. These waivers, we received notice last week. It was, I think, April 7th, if I recall. We received notice that many of these waivers are now coming to an end. They were meant to be emergency waivers, and though the emergency declaration of the pandemic has not yet ended, it's my understanding and our understanding at Mountain Pacific that the certain language in those waivers will be ending. Now, most of the waivers that pertain to long-term care are a 30-day waiver ending date or a 60-day. So let's take a quick look at those if we could on the next slide, please. So for example, the waivers that are the waivers that I think you'll most want to pay attention to upcoming, which will expire within 60 days from the April 6th issuance of that notice, are the paid feeding assistance. Paid feeding assistance, the language in the waiver articulated that paid feeding assistance would, they changed the minimum number of hours for training from 8 hours to 1 hour during that waiver period. That will be returning to 8 hours beginning on June 6th. In-service training, the in-service training of 12 hours annually was paused also during the during the emergency declaration waiver. And that too will be coming to an end on June 6th. So you will want to begin to think about incorporating those annual training hours for your nursing staff that required those 12 hours, and that was your nursing assistants. And then finally, trained and certified certification within 4 months of hire for nursing assistants. That will also, you'll have until October 6th to get everybody that's in-house now trained up through a certification course. And then they also have to pass competency for their testing. They will also have to be certified in your state. And I know that's different in every state, how that's managed and governed. I know in my state, it takes about 45 days to process a certification for somebody because of background checks and fingerprinting, all that needs to happen. So this goes into effect June 6th, and then you have 4 months, because remember, whenever you hire somebody, now that the waiver will be ending, so anybody hired after June 6th will have 4 months in which to become fully certified in their scope of work and in their state. All right, next slide, please. There are a couple of examples for the 30-day waiver ending dates. Now, we too, Mountain Pacific, we get the same information that you get when these memos come out and these changes come out. And so we're really working through these the best we can. So we don't claim to be experts on all of this. However, we are happy to, if you have questions, we're happy to take those questions and seek answers for you. So we don't, this is the language that was present in the waiver, and that is that ending on May 7th, which is 30 days from that notification, is the physician visit piece where CMS, this is the language that's in the waiver. This is not the language that happens on May 7th, by the way. So the original waiver language on the screen here is that CMS waived the requirement for physicians and non-physician practitioners to perform in-person visits, and then for nursing home residents, and then also allow telehealth options. So I think there are perhaps some other remedies and some other alternatives for telehealth, but that certainly should be explored with your state survey agencies. Next slide, please. Also on the radar for a May 7th ending, again, 30 days from the issuance of the waiver notice, of the ending of the waiver notice, are your QAPI programming. A lot of that was paused during the pandemic time period. Physician delegation of tasks, resident group meetings, and then note to facilities. So you can read for yourself. Since we're kind of tight on time, I won't read through that specifically, but just be aware that you'll want to take a look at that waiver language and know that that's the language in those waivers is what's going away on the particular dates. And again, if you have questions, please do reach out. We'll get to the bottom of it. And then I think I have one more slide, Mary. I also wanted, this is not something that changed in April, but this has been something that's been tripping up a couple of nursing homes that I've worked with, and that is, it kind of happened under the radar, but there was a change back in November regarding the educational requirements for dietitians, and then the qualifications and the designation for a director of food and nutrition services person. So this particular waiver language ended, like I said, back in November of this past year. And there are some real stipulations on what the criteria is and credentialing needs to be for your dietitians and also for anybody who is in your food services department. So if you have any questions at all, it's laid out pretty nicely in that waiver language, and there are other places we can help look for that information. But the trainings are meant to be significant. Most of them range in length from a minimum of 18 months to 4 years. I do know that a lot of dietary managers become certified in their work, and that is acceptable, but that will have to happen within a certain period of time after hire. And I think it's usually within 1 year after hire. So just be aware that those are guidelines that have changed and are being surveyed to, and I just don't want you to get tripped up on any of that. So that's kind of a very high overview of some of the language changes with the waivers and also with the attachment A regarding the vaccine mandate and survey process. So I don't know if we have any questions that I can answer, or if I want to turn it over to you, Jesse, and then we can look at questions at the end if you'd like.
Well, I have a question that came in here, Jill. Does the same time frame apply for CNAs, that all staff must be certified in critical access as well, swing, intermittent, intermediate, and skilled, or are their regulations different?
I think we would have to look and see. It seems like that the handout that I've been referencing, the one that I put in the on the slides, has to do with skilled nursing facilities, and there are some, I think, other languages for critical access hospitals and also some other alternatives. So I think those would have to be researched individually. I would hate to say that they're for everybody.
Okay. Okay. And then an additional question, also wondering if they can practice at the hospitality aid scope or currently can do CNA scope.
So that's a great question, actually, also, because you know, if you have somebody who is struggling to get into a class or struggling to pass the class, perhaps, then you can continue after October 6th to utilize them as a hospitality aid is a great way to utilize folks like that to keep them interested in our work and to keep them engaged. You know, you just hate to lose anybody who really wants to do. The work is hard. And so if there's somebody who's really wanting to do this and they're just struggling to get into a class, like I said, or to pass it, then you certainly can use them in other areas. You can have them work in activities. You can have them do non-CNA kinds of duties that are also very helpful, like hospitality aid, and can be a great support to the certified nursing assistant staff. You know, I did want to maybe mention also that it's really a good idea to keep some notes. If you have anybody who's, there are some states that have kind of some testing backlogs and some jamming up. And so it's really important that if you are one of those states that's experiencing that, it's really a good idea to stay in great communication with your survey agency. Keep notes of who you've called, the attempts that you've made to get folks into classes. Any barriers that you've encountered, all of that needs to be, I would keep special documentation just for that. And then I would keep the lines of communication open with your survey agency. So if there are barriers, I know we all live in kind of rural states, and sometimes there are access issues. And so certainly, you know, to be proactive in those, if you should encounter those barriers or glitches, it would be very helpful to you. I mean, even if you have somebody placed on a wait list to get into a class, the day that you made the call, that, you know, the follow-up calls and the efforts that you've made to try to get your staff trained is also really worth keeping on record.
All right, thank you, Jill.
You're welcome. Thank you.
All right,
All
Mary.
right. Yep, we're up to you now.
All right, well, thank you guys. I just wanted to touch upon immunization information systems, or IIS systems. Take that opportunity to share this resource forward with you guys today. Next slide, please. So essentially, what are these systems? Why do they exist? And what information is in them? Well, these systems are also known as immunization registries or immunization information systems. They're a system that essentially houses the vaccination information for an individual. It's important to comment that there's actually no standardized federal system. All of our immunization systems are state specific, even city specific, and operate on their own systems. So this resource essentially, it helps to keep those immunization records, provide quicker access to those records, and keep track of those patients' status. Now, you know, why do they exist? They started in about the 70s to help keep track of children's immunization records, and they've kind of morphed and evolved into tracking of adult immunization records. And as you can see, our vaccinations and immunizations come from a variety of places. So these systems, IIS systems, help standardize and allow for accountability as well as tracking of our vaccines. So what information is in these systems? Again, it varies by state, but most contain at least your name, your birthday, the sex, patient birth date, or excuse me, patient birth state, mother's name, and the types of vaccines given, and then those days that those were given. Next slide, please. So why is this important and how can this help me? So why I'm bringing this forward is really this immunization information system. It's important for two different reasons and two different viewpoints. The first point is for clinical care. It can help a provider consolidate immunization histories, track immunization histories, and then determine what immunizations are appropriate for a patient. The second point or second level at which these systems are important is for population level. So it can provide data on vaccinations to be used in surveillance and program operations, help guide public health action and goals for improving vaccination rates, and really ultimately tell us where there's the ability to reduce vaccine preventable diseases by regions and populations. So how can this help me? How can this help me? So really, here's the win for you, our partners that are on the line today that are in the long-term care setting. Historically, these systems have really been underutilized. And we all have thumbed through charts and papers and admit paperwork trying to verify and find vaccination status. Well, now, because of the COVID vaccination and the reporting requirements around the COVID vaccination, as well as rules that were tied to it, we find the need to track down vaccine status information more valuable today than previously. So this system you can enroll in, and you can check that new admissions vaccine status immediately, not having to reach out to a third party, and timely. And then ideally, this could help assist in more accurate NHSN reporting. So how can I enroll? Next slide, please. I have reached out to our servicing regions, Guam, Montana, Wyoming, Alaska, Hawaii, and obtained all the contact information for you guys to reach out if you're interested in gaining access to these immunization systems. I will note that what we're seeing with some of the communities is you may have access within your center, but due to staff changeover, you just need to update your user IDs. And again, these specific contacts can assist you with that updating. And these slides and everything, as always, will be available after the presentation so that you guys will have this information. Next slide, please. For Wyoming and Alaska. And next slide, please. Hawaii. And I don't know if we have any folks on the phone from Hawaii today, but I do understand that there's a very large number of long-term care facilities that are enrolled. So I found that of interest. A couple questions about this that have come up. Again, there is no cost to enrolling in this program. There is no charge. Next slide. And these are, the IIS programs can exchange data with EMARs and EHRs. It just depends on the module that you have with your electronic health record. Some are going to be easier than others, but this question has come up a couple times. This is an initiative in some regions to have these two entities talk easier. The capability is there. Again, it's just based on the module that you have within your electronic health records. Next slide, please. And then, ultimately, if you're having a little bit of difficulty getting enrolled or it's taking a little bit and you need further assistance in getting that vaccination status so that You can keep track of your immunization records for those admissions. Feel free to reach out to your local county health departments and they can assist you. If you have a primary pharmacy that has been the primary provider of your COVID vaccines, they can also look this information up pretty easily for you. But again, I encourage everyone, as it's historically been underutilized, take a look at enrolling and gaining access to our state's IIS systems. Next slide, please. Oh, and there's some resources for you guys. Any questions?
Hey, Jesse, couple things. First of all, this is Jill again, and I did look back. Can I share my screen, Mary, just for a second, please? I did look back to that question regarding, second here. Okay, can everybody see this screen okay? Is everybody seeing the CMS memo on your screen by chance?
No, not yet.
How about if I hit this button now?
There we go.
Can you see the CMS memo?
Yes.
Yep.
Yeah.
Okay. So as I pulled up this memo, this was the question regarding whether these waiver ending, these waivers that are ending, if they were applicable to critical access hospitals or hospitals in general. And it looks to me like, based on this memorandum summary, that it is not applicable. In other words, applicable waivers will remain in effect for hospitals and critical access hospitals. So this particular language that I shared earlier is relevant really just for these folks here, the intermediate care facilities, nursing homes, inpatient hospices, and looks like end-stage renal disease facilities. So that's that question answered, I hope, anyway. And then I think there was a question in the chat, Jesse, where Vanessa's asking, I recently asked a question and have received some pushback regarding testing and booster dose eligibility. Staff who have recently completed their primary vaccination doses are not eligible for booster dose. Are we to consider these individuals not up to date and require antigen testing at a frequency directed by the county's transmission rate? I can tell you that this question came up in Wyoming, and the response from the state EPI office, Vanessa, was that if you have received the most recent, if you are in a place where you have received everything you can possibly receive, that means you have optimal coverage, and so therefore you would not fall into the category of needing increased testing. Does that make sense? I kind of stumbled around that, but basically you are as up to date as you can be. And so you're considered to have a high level of protection, meaning that you would not then be required to submit to the testing. However, if you have somebody who is 1 week past their eligibility time for their booster, they would have to succumb to the testing or all the other requirements that would fall into those folks who are not up to date. So you'd want to keep really close, tight records on their dates and timelines for their vaccinations so that you can make sure nobody falls through the cracks. Does that help answer the question?
Yes, thanks, Jill. Vanessa said thank you.
Okay, great. You're welcome.
We have another question in the chat, and then while we discussed that question, I just threw in a polling question too. If you guys that are on wouldn't mind taking the time to respond, that would be great. Jill, do you have clarification from CMS on up-to-date masking for staff? I've heard some facilities are not requiring staff that are up-to-date do not have to wear a mask when not around residents or patients.
There was, yes, and there was some clarification about that. And so if you have a staff member who is up to date and is not in a resident area and wants to take a break, is not in an area where residents can access, then they can remove their mask during that time frame. What's still pending is whether what their approach should be if they have a colleague that's around them that is not up to date. And so I think this really only applies to an audience of everybody being up to date. And I think in Wyoming, the state epi office put a call in or have reached out to CDC for some additional language. But for now, I think if you have a staff member who is in the break room and they're in there by themselves, they certainly can take, and they're up to date, they can take their mask off and enjoy some time without their mask during that particular time.
Thank you, Jill. And we have another question here too. Really good question. Is the second booster now going to be considered part of that up to date for those eligible?
Michael, if I knew that answer, I would be in Vegas right now. You know, I think that currently is not part of the mandate language. And we don't know. We don't know that answer at this point.
Jill, I can add one comment about that.
Yes.
The recommendation from the CDC is a may get a second booster instead of a should get a second booster. So just a little bit of clarification and something that might make a difference in what the policies will be moving forward.
Thank you, Kyla. You're right. That's exactly the case. May and should, may and shall. Good point.
And then Mary, I don't know if we're able to open that polling again or if it resets it.
Did you want to run it again?
Will it reset the current data if we do?
Yes, it will.
Oh, okay. Okay. Well, Deb, feel free to answer in the chat or send me a direct message and I can add you into my data collection. Yeah, thank you, Deb. Well, thank you guys. If anyone has any questions, feel free to reach out to us as always. If there's anything that we can do to be of assistance of or with, we are here. So I believe this will conclude our 13th edition of It's Worth a Shot series on today, April 13th. Thank you, everyone, and have a good afternoon.